Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, A Randomized Control Trial of Survivorship Care Plans Among Low-Income, Predominantly Latina Breast Cancer Survivors by Rose Malley et al. My name is Nina Bickel, and I'm a professor in the Departments of Population Health Science and Policy and Medicine, and co-director of the Center for Health Equity and Community Engaged Research at the Icahn School of Medicine at Mount Sinai in New York City. I'm a general internist and health services researcher devoted to eliminating disparities in cancer. Treatment Summary Survivorship Plans are a challenge. The Institute of Medicine identified 4 critical components to cancer survivorship care. 1. Prevention of recurrent and new cancers and other late effects. 2. Surveillance for cancer spread, recurrent, second cancers, medical and psychosocial late effects. 3. Intervention for consequences of cancer and its treatment. And 4. Coordination between specialists and primary care providers. Each of these elements demands significant investment to produce and ensure accurate reporting and implementation. They require a tremendous effort to produce but are not reimbursed. ASCO and the Commission on Cancer include survivorship care plans as quality standard measures. Most sites still struggle with ensuring accurate staging and collecting treatment summaries that are required reporting for accrediting bodies and payers like oncology care models. To date, the push for treatment summary survivorship plans has been based on its face validity. Evidence of treatment summary survivorship plans' effectiveness has been lacking. A 2015 systematic review of survivorship care found several studies, physician-led and nurse-led survivorship care models, in which some focused on survivorship care plans for survivors, others compared group versus individual counseling of survivors. None addressed direct coordination or communication between clinicians. And the outcomes they most commonly assessed were quality of life, anxiety and distress, as well as patient satisfaction. A couple assessed overall survival and some rates of recurrence. Most of the study were feasibility pilot studies, and the one randomized trial included in the review found no impact on survival or recurrence, though the counseling and exercise intervention did improve quality of life. But that review did not include 2 important trials. Grunfeld's landmark randomized controlled trial of survivorship care plans randomized breast cancer patients who completed treatment less than 2 years or more than 2 years prior to receive a survivorship care plan which they reviewed with a nurse. Their primary care physician also received a survivorship care plan along with a guideline on follow-up. The trial was negative. The survivorship care plan patient education session coupled with physician intervention did not affect patients' level of cancer-related distress, quality of life, patient satisfaction, health status, continuity or coordination of care, or utilization of visits to primary care physician and oncologist. Similarly, Hirschman et al. Randomized breast cancer patients within weeks of completing adjuvant therapy to meet with a nurse and nutritionist to review their treatment summary, surveillance, and lifestyle recommendations. All patients, intervention and control, received a National Cancer Institute pamphlet on survivorship. Patients were surveyed at 3 and 6 months, and there were no significant differences in patient satisfaction and impact of cancer, but intervention women had less worry. They did not assess ongoing surveillance or unmet needs. None of these trials identified underlying needs or matched women to interventions that specifically targeted their needs. In the absence of clear impact, it's challenging to justify and demand an investment such as treatment summary survivorship plans. And with the growing number of cancer survivors and practice investment required to complete treatment summaries, let alone interventions to address unmet needs, the current randomized trial by Malley et al. Is a welcome and important study. There are several significant elements of this trial. One, it targeted vulnerable breast cancer patients, stages 0 through 3, a group who are more likely to have significant unmet needs. The population was recruited from public hospitals and included 73% Latina and 91% with incomes less than $30,000. And two, it identified a series of 23 different underlying needs ranging from wellness through psychosocial issues, physical signs and symptoms, and ongoing surveillance of breast cancer as well as bone health and screening for other cancers, and sent this data to the breast clinic. This multifaceted intervention targeted the 4 critical elements cited in the IOM report, namely prevention, surveillance, intervention, and coordination. Based on each woman's needs assessment, a treatment summary survivorship plan was developed addressing each underlying survivor care need. The treatment summary survivorship plans included suggested evidence-based interventions and was based on the Journey Forward Survivorship Care Plan Builder adapted for low literacy and Spanish-speaking patients. For example, if a woman was having hot flashes, the physician would be recommended to order venlafaxine or gabapentin and refer her to a gynecologist. If a woman had general anxiety, recommendations included referral to a support group or for counseling or cognitive behavioral therapy. Women were coached to write down their 3 most important questions to help empower their communication with their physicians. In a 1-hour session with a trained research nurse, each woman reviewed her treatment summary survivorship plan. She role-played discussions, including how to ask for survivorship care recommendations. Each woman was encouraged to see the physician most involved with her cancer care to review her treatment summary survivorship plan and question list with that physician. She was also given 2 copies of the treatment summary survivorship plan to bring to future visits with other providers, and copies of the treatment summary survivorship plan were mailed to chiefs of the breast clinics at the study sites to be scanned into patients' medical records. The primary outcome was physician implementation of specific recommendations for each survivorship care need and was assessed across the 12 months of follow-up and was based on patient-reported receipt of a specific recommendation for a previously identified need and whether the patient had acted on any of the recommendations. The primary outcome was the sum of the number of needs addressed divided by the total number of survivorship care needs times 100. At baseline, the intervention and control groups were similar in terms of knowledge of survivorship issues, satisfaction with care and information. They found that the average number of survivorship care needs was 5.4 with a range of 1 to 17, with the intervention group having slightly higher numbers of needs, 6.5 versus 4.3 in the control group. The most common concern was about weight, with 82% of intervention and control group women expressing this issue. This was followed by concerns about risk of recurrence, with half of women expressing this concern. Insomnia, depression, and joint aches were close behind, with 40 and 35% of women declaring these symptoms as problematic. The groups did differ in needs, with 48% of control women, but only 2% of intervention women, having concerns about employment, insurance, or finances. Control women also had more joint ache, fatigue, hot flashes, and pain. Physicians were more likely to implement a treatment summary survivorship plan recommendation for intervention than for control patients, with a median of 66.7 versus 50. And intervention patients were more likely to be satisfied with their care and information, than control patients. Out of the top 10 needs, only 2, weight gain and hot flashes, were addressed more often by physicians in the intervention group compared to the control group. Women in the intervention group were more likely than those in the control group to adhere to physicians' recommendations, but this difference did not reach statistical significance. Certain care needs were associated with greater patient adherence to recommendations than others. For example, women were more adherent with recommendations about weight gain than for hot flashes. It's uncertain why this was the case. The number of needs for which recommendations were given did not affect patient adherence. Unfortunately, we don't know how bothersome or impactful the various survivorship needs were on women's lives, or how helpful the interventions were to address those needs. While the intervention did seem to exert greater patient adherence for women complaining of weight gain or being overweight, how well and how long it affected this concern is not detailed. There were no measures of utilization of preventive screening for breast or other cancers, or of communications between oncologists and primary care physicians, or whether sites differed in best practice alerts for cancer screening. Over the course of the year, there were no significant differences between the groups in change in health status or patients' efficacy to communicate with their physicians. What we do know is that among a population of vulnerable patients, significant proportions of new breast cancer survivors have needs. Many of them have multiple needs, and this Treatment Summary Survivorship Plan intervention helped address some of them. More work needs to be done to understand which needs negatively impact patient health and well-being and require intervention to resolve, and what are the best ways to encourage both physicians and patients to adhere to treatment recommendations. Malley's randomized controlled trial is the first evidence showing that treatment summary survivorship plans may be worth the investment. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.